A.D.محمد, which is we do laparoscopic gastrectomy with colonic position for recurrent cancer in the gastric tube after McEwen hysterectomy.
Thank you for kind invitation. We have a 35-year-old female patient diagnosed with recurrent cancer in the gastric tube 4 years after McEwen esophagectomy and managed by reduced thoracoscopic gastrectomy with colon interposition. We started our procedure by diagnostic thoracoscopy to exclude metastases. The first issue in the thoracic part is that the gastric tube was cariated based on the right gastro-block vessels at the adjacent omentum. Omentectomy is a crucial step for achieving adequate lymphadenectomy to maximize the benefit of resection. The second issue in the thoracic part is that how to identify the tracheobronchial bifurcation among the adhesions of the previous procedure, because the plane is quite difficult at this area because it is a site of recurrence. So once the previously clipped azygos vein was identified, I follow the plane between the gastric tube and the anterior located trachea. It is difficult to use harmonic scalpel to dissect the gastric tube away from the anterior located trachea. In the superior mediastinum, the plane became more easier, and after that we turn the gastric tube to the right side and start to harvest the remaining perigastric lymph node in the superior mediastinum. And I went back to the inferior mediastinum, identifying the left lobe of the liver. And here is the final view after dissection of the gastric tube. Then we moved to the abdominal part, started with diagnostic thoracoscopy, and I visualized the remaining part of the gastric tube and separated it from the first part of the duodenum, and start to prepare the colonic graft, started coherization of the right colon till the splenic flexure, and starting clamping test on the ileocolic, right colic, and middle colic vessel to assess the length and vascularity of the colonic graft. Then we move to the neck part. The key point here is identifying the left recurrent laryngeal nerve, because it's the anatomical landmark to deliver the previously created esophagogastric anastomosis in the neck, and start to separate the proximal part of the gastric tube away from the remaining part of the esophagus, just 2 to 3 centimeters below the pharynx. Then we hang the specimen on 2 long esophageal tape and retrieve the specimen through the abdominal wall, hang it on 2 long esophageal tapes, and separate the 2 long esophageal tapes and insert it in the colonic graft, and start to pull up the colon to retrieve it through the neck. Here we have a colonic graft formed of terminal ileum, appendix, cecum, ascending colon, and medial 2/3 of the transverse colon. Then prepare the colonic graft by resection of the terminal ileum, appendix, and the cecum, and for later on anastomosis with the remaining part of the esophagus in the neck. We performed an anastomosis between the esophagus and proximal part of the colon, hand-sewn anastomosis, single layer with BDS-20. Then we went back again to the abdominal part and start to anastomose the distal part of the colonic graft with the alimentary limb of the jejunum 40 centimeters away from the DJ. Here is the second anastomosis. The third anastomosis is the jejunal anastomosis, side-to-side anastomosis also by stapler, and close the print by BDS-20. After 40 centimeters again, we put an jejunostomy tube, and the latest anastomosis was between the terminal ileum and the lateral 1/3 of transverse colon to restore the whole GIT continuity, and the closing of the defect to avoid later on internal hernia. Pathology post-operative was very satisfactory. We harvested 2 lymph nodes of 15 lymph nodes with free surgical margin. Thank you very much.